Hello, I'm Dr. Rebecca Bernard, and thank you for joining me for a discussion of the importance of physician-led care. I'm the co-author of the book, Patients at Risk, The Rise of the Nurse Practitioner and Physician Assistant in Healthcare, along with my co-author, Dr. Nouran Al-Ajba. And I'd like to thank the American College of Legal Medicine for inviting me to come and speak, along with my colleague, Dr. Amy Townsend. We're both board members of Physicians for Patient Protection, which is a grassroots organization with a mission of ensuring physician-led care for all patients and ensuring truth and transparency regarding healthcare practitioners. We invite all physicians to join us at physiciansforpatientprotection.org. The reason that we're here is because of patient safety, and I'd like to tell you the story of Alexis Ochoa. She was a 19-year-old woman with straight A's. She was a college basketball player. She was an athlete. And she was in very good health until one day she suddenly developed acute chest pain, shortness of breath, and she fainted. When she fainted, her boyfriend called 911, and an ambulance picked her up at her dorm room and took her to the nearest emergency department. When Alexis got there, she told them that she had no other medical history. She took birth control pills, and her vital signs were noted to be quite unstable at the time, with an elevated heart rate and a low oxygen level. When Alexis arrived, she was greeted by a nurse practitioner, Antoinette Thompson. And Ms. Thompson was an experienced practitioner in the sense that she had worked as an emergency room nurse. She had previously been a firefighter paramedic, but she really had not been a nurse practitioner for very long. In fact, she had just graduated and passed her certifying examination just a few months before she was hired, and just 8 months before she began to treat Alexis Ochoa. She had gained her 500 hours of clinical experience taking care of pregnant women, providing prenatal care. These were low-risk women at a county health department. And she achieved the rest of her education through online training at the University of Southern Alabama. So Antoinette was there taking care of patients all by herself in the emergency room. There was no physician on staff at the time that Alexis arrived. And that was in contrast to the information provided on the hospital's website. So this hospital was owned by a larger corporation called Mercy Health Systems, a multi-billion-dollar organization with hospitals and clinics across the area. And they advertised on their website that their emergency department was, quote, staffed round the clock with a team of highly trained emergency physicians. But when Alexis arrived, there was only a nurse practitioner, and not even an emergency trained nurse practitioner, but a family nurse practitioner who had been hired to work in an acute care role, even though she really didn't meet the criteria. And the Mercy Health Systems Corporation also allowed routinely nurse practitioners to staff the emergency room without a physician on site. So unfortunately, the nurse practitioner did not properly diagnose Alexis. She misinterpreted a lab result as showing that the young woman had methamphetamine in her system, which she did not. And she kind of got fixated on that diagnosis. And so she treated Alexis for about 11 hours with various medications, and the patient just got sicker and sicker. Never once during those 11 hours did Antoinette contact her supervising physician. In fact, it seemed from testimony that she really didn't even know who that was. She did reach out to a consulting physician at one point, and at that was when she finally transferred Alexis to a tertiary center where she was properly diagnosed with a pulmonary embolus, but unfortunately she died. The family sued the facility, and they did win a $6.19 million verdict against Mercy Health Systems. And part of their complaint was that they didn't even know that they were being treated by a nurse practitioner. They were under the impression that they were being seen by a physician. Well, even though this verdict was won, Antoinette Thompson continues to practice as a nurse practitioner. She left Oklahoma and she took employment in Iowa. And at the last time I checked, which was not too long ago, she was listed as an emergency provider in Iowa at Veterans Memorial Hospital, taking care of veterans. Iowa is an independent practice state, as is the Veterans Administration. So one can presume that she may be continuing to care for patients without physician supervision even now. It took several years for the Oklahoma Board of Nursing to do anything or take any action against Thompson, even though her care was not proper. And finally, they did sanction her, and they suspended her license for 1 year and required her to pay a $1,000 fine and take some remedial coursework. So, how did we get to this point? Just reviewing the history of nurse practitioners, the first professional nurse training program was founded in 1872, actually by a woman physician by the name of Susan Demock. And Demock had attended medical school at the University of Zurich because Harvard, where she applied, was not accepting women physicians at the time. When she came back to the US after her training, she opened a nursing program, and she kind of was following the Florence Nightingale model of training nurses with didactic education, textbooks, and formal education rather than an apprenticeship type model. The nursing profession rapidly grew in the early 1900s, especially with an expansion of inner cities. And there was an increased need for public health nurses because as people moved into inner cities, there were more cases of tuberculosis and other infectious diseases. So the importance of nursing really began to grow at that time. In the 1950s, nurses moved from hospital education system into universities. And the very first nurse practitioner program was founded in 1964 by Henry Silver, a pediatrician, along with Loretta Ford, a nursing professor. And the idea was to create physician extenders that would focus on well child care, especially in underserved areas. But it wasn't long before this rapidly grew and began to change. So the first program was in 1964. In 1972, the US created a federal committee to study an extended role for nurses because there was a prediction of a physician shortage. In less than 10 years, we went from one nurse practitioner program to 65. Now we have 400, by the way. And the government continued to invest in nurse practitioner training programs. In fact, in the 70s, there were rural health mandates that required that all clinics in rural areas that receive federal funding must hire a certain proportion of nurse practitioners or physician assistants. And so there was a lot of incentives from the government to increase nurse practitioner training. Over time, nurse practitioners began to gain more autonomy and independence. They got provider status in the late 80s. In the 90s, they were able to be paid directly by Medicare. And then beginning in the 80s and 90s, they began to seek what they call full practice authority, starting in the rural states, but then rapidly moving to other states. This is a map that shows where nurse practitioners have independent practice. This is from 2019. Green means that they have full practice without any physician supervision requirement. Yellow, they have some restrictions, but can practice somewhat autonomously. And then red, they are not allowed to practice without physician supervision. Although you see, I've marked here that California last year did pass independent practice, so they're no longer red. Florida passed independent practice for certain primary care nurse practitioners last year. This year, they're seeking expansion into all specialties. And Virginia also allowed independent practice after working for 5 years. So we are definitely seeing a big increase in nurse practitioners, and part of that has to do with a report that came out in 2010 by a group called the Institute of Medicine. And this was an organization that was funded by private philanthropy and government, and it included 18 members on the board that produced this Future of Nursing report. And those members of this board was led by Donna Shalala, a politician and former college professor. And she was joined by a large number of nurse practitioners, some think tank advisors, some heads of industry like drug companies and insurance companies. And there were 3 physicians, although one of them was the head of a pharmaceutical company, one was the head of an insurance company, and one was in academia. So this 18-member board came up with something called the Future of Nursing Report. And what that did was call for an increase in the number of nurses with a doctorate degree, as well as bachelor's degrees, so that they could go on to become nurse practitioners, and also said that nurses should be able to have full partnership with physicians, so calling for equality. And in that same year, the government intervened again to increase nurse practitioner training through the Affordable Care Act, which authorized billions of dollars to expand nurse practitioner training and also created new nurse-led community health centers, but interestingly did not do very much to increase physician residency slots. So here you can see the increase in nurse practitioner graduates over time, really big jump happening around 2010 based on that increase in funding for training. So let's just talk about how they accomplished this. And really, I mean, if anything, we should be kind of impressed with the efforts that they made to take a profession that's relatively new from the 1960s and to gain independent practice in nearly half of the states of the Union. It's really quite amazing. And they did that through cooperation. Nurse practitioner leaders of something like 130 different organizations came together to form a summit in the 1990s, and they decided to put aside any differences of opinions and focus on one thing, which was to gain independent status. They also worked really hard for political advocacy, and they received a lot of funding, especially from philanthropy, which we'll talk about. I really want to focus on the Robert Wood Johnson Foundation because this is a group that's really been very interested in expanding nurse practitioner practice. It's the largest United States health-focused philanthropy. They had $11.4 billion in assets in 2017, and they've contributed $674 million since they were formed to promote the work of nurses. And one of the ways that they've done that is they've created these executive nurse fellowships, which have allowed nurses to go into areas of politics, into Washington, D.C., into state capitals, to develop political relationships and to learn how to work side by side with our legislators to influence healthcare policy. Robert Wood Johnson also subsidized the Future of Nursing report. It was their idea to make it and they funded it. And then they also funded efforts to implement the recommendations of the report using the AARP. They have a strong relationship. And they also developed relationships with media like National Public Radio, where they've given millions of dollars to promote healthcare, what they call new avenues of healthcare reporting. So often a lot of really positive PR for nurses and nurse practitioners. So why is it that Robert Wood Johnson is so interested in supporting the work of nurse practitioners? Well, first of all, Robert Wood Johnson Foundation is the philanthropic arm of Johnson & Johnson, which is one of the world's largest producers of household products as well as medications. They have several subsidiaries, for example, Janssen Pharmaceuticals, which is a major producer of opioid medications, among other medications. And they also have relationships with CVS, which owns Minute Clinics, which often employ nurse practitioners. So you as a patient can go into a CVS, you can be treated by a nurse practitioner, you can be prescribed a medication that you will fill at that same CVS, and that medication may have been produced by Johnson & Johnson or Janssen. Of course, this is all just speculation, but you do see that there are a lot of links between these different organizations, and there's a lot of potential financial gain when they work together. There's also a relationship with the Robert Wood Johnson Foundation and the AARP, American Association of Retired Persons, which sells supplemental insurance plans to seniors and has a relationship with United Healthcare, and then also Optum RX, which is a pharmacy benefit manager, which would provide medications possibly provided by Johnson & Johnson. So we don't know all of these relationships, but we do see that there are links there. So let's talk about nurse practitioner scope of practice because it's very confusing, and even nurse practitioners themselves often spend a lot of time discussing the nuances of scope of practice. So because there are so many different types of nurse practitioners now, back in 2008, some groups of nurses got together to try to create a consensus model. And what they did was they categorized nurse practitioners into 4 groups: certified registered nurse anesthetists, CRNAs, certified nurse midwives, and then 2 categories. One is called clinical nurse specialists, and the other is certified nurse practitioners. And clinical nurse specialists are more likely to be seen in hospitals, and they tend to be more like nurse managers, whereas certified nurse practitioners are more like active providers or taking care of patients perhaps at the bedside or outpatient. So for the topic of today, we'll focus on the largest group, which are nurse practitioners. And the consensus model further divided them into population focus. And the population focus is family or the individual across the lifespan, which is called FNP. And this is the largest category of nurse practitioners. After that, you have the adult geriatric nurse practitioner, the neonatal, the pediatric, women's health nurse practitioners, who, by the way, are also permitted to care for newborn babies and also the partners of the women that they treat. And then psychiatric mental health, which is also considered across the lifespan, including children and vulnerable individuals. And then nurse practitioners can also be further certified into primary care, which would be like a family nurse practitioner. And then they could get acute care certifications. So technically speaking, primary care are supposed to be taking care of stable patients, more outpatient, whereas acute are supposed to be more certified for treating patients in an urgent care or an emergency setting or an unstable situation. The specialty care nurse practitioner really does not exist in the consensus model, and there really isn't a lot of clear guidelines on who can just open up an office and call themselves a specialist after taking maybe a boot camp course or shadowing another physician or a nurse practitioner. So that's one of the issues that we're seeing is there's really no real standardization. So just to talk for a few minutes about physician assistants, because we should know what they're doing, they're also following a similar trajectory to nurse practitioners and seeking independent practice. And it's interesting because the first PA program was founded around the same time as the first nurse practitioner program in 1965, and also by a physician, but at Duke University. And the idea was that there were a lot of military corpsmen returning from Vietnam, and they had some medical experience. So Dr. Sneed hoped that he could help take these medical corpsmen and give them a little more training so they wouldn't be as trained as physicians, but they would have enough training, especially to go into underserved areas. So, and then our friend Dr. Henry Silver, who made the first nurse practitioner program, created a PA program as well at the University of Colorado, and he called his PAs child care associates. And again, the idea was to provide well child care. But in the 70s, with a projected physician shortage, federal funding began to train PAs to work in primary care in rural and underserved areas. So for a while, PAs were pretty content with working very closely with physicians. They do train on a little bit more of a medical model versus a nursing model. But in recent years, perhaps due to increased economic pressure from nurse practitioner independence, they've been seeking independent practice as well. And they call it something called optimal team practice. And the idea is that rather than being locked into working under the supervision of one physician, they have more flexibility. They can work under a group of physicians. They could work under the designation of a hospital or a medical facility. And then in some areas now in North Dakota, they actually have one independent practice. And South Dakota was recently hearing a bill which failed in committee, but could come back to seek the same privileges. And here's just showing the growth of physician assistants, not quite as exponential as nurse practitioners, but still a nice increase in growth. So what is the difference in training between the professions? We know, those of us who are physicians in the audience, that you must have at least 4 years of college. You must attend, unless you're a baby doc, then maybe you can cut off a year of college. But most of us go through 4 years of college. We know that we all must complete certain prerequisites in the hard sciences. Everyone has to do that regardless of your major. And then you have to attend 4 years of medical school. And then that's not enough. We cannot be licensed as physicians unless we complete postgraduate training. For most of us, the minimum is 1 year. In some states, it's more. But for US trained physicians, in some states can practice after 1 year. Others, like in California, must complete a minimum of 3 years. And most physicians complete at least 3 years, if not more. And all foreign graduates from outside of the United States must complete at least 3 years of postgraduate education to be licensed to practice medicine. Now, nurse practitioners typically attend nursing, they first attend college. They usually get their nursing degree there, a bachelor's of science in nursing, although they can get an associate's degree in nursing or an RN diploma degree, and then later on complete their bachelor's. Sometimes they do programs while they're working to achieve their bachelor's. Once they have a bachelor's, then they'd go on to a nurse practitioner program, which could be anywhere from 1 to 4 years. Or they can get a doctor in nurse practice, which we'll talk about in a little bit. And there is no residency requirement. So physician assistants have a 4-year undergraduate degree. The PA program is typically 2 to 2.5 years, and then they do not have to complete any residency. So if we actually just look at the hours of training, you see for physicians, it's estimated that by the time we finish our residency, at a minimum, we have completed about 15,000 hours of supervised practice. Nurse practitioners are required for their master's degree to complete a minimum of 500 clinical hours. If they get a doctorate degree, then they have to get another 1,000 hours. And physician assistants are estimated to receive about 2,000 clinical hours during their training. Just for comparison to see how many hours are required for different professions, because I think it's really interesting. So nurse practitioners have to have 500 hours to be able to take care of patients, and in some states they can be independent. But yet to become a barber, you need to have 1,800 hours of clinical practice, or not clinical, but of haircutting practice. You need 1,500 hours to apply makeup. To be a cosmetologist, you need 600 hours to apply makeup. So you need more hours to apply makeup than to take care of patients' health. So it's really interesting. And even PetSmart's dogs groomers must complete a minimum of 800 hours of training before they can cut and groom dogs' hair independently. So there's definitely some concerns about the minimum requirements. And one of the things that's really interesting is that there was an experiment done back in 2008. So this doctor of nurse practice was a relatively new phenomenon. Previously, nurses that wanted to continue their education and get an advanced degree, they would go for a PhD or an educational doctorate degree so that they could go on to teach. So the DNP degree was relatively new, and the idea was to come up with more education for nurse practitioners to gain more clinical insight. Unfortunately, what's turned out to be is that only 15% of all the doctorate programs are actually clinical, and 85% of them are non-clinical, but that is not always being communicated to patients. But back when they were first trying to get this doctorate program started, the group worked with the National Board of Medical Examiners to see if these doctoral candidates could pass the same exams as physicians. So they gave the nurse practitioners that were getting their doctorate degree a version of step 3 of the USMLE 3. Now, this was not the exact same one that we took as physicians. It was a little bit watered down. In fact, the National Board of Examiners published a white paper about it where they said that it was not designed to replicate the USMLE, and quote, it does not include the in-depth assessments of fundamental science, clinical diagnosis, and clinical skills that are provided for USMLE for physicians. But so this was a milder, less strenuous version. And you see here that the first year they offered it was in 2008. They had 45 candidates take it, and they had only a 49% pass rate. And the last year that they offered it, they only had a 33% pass rate. And at that point, they discontinued this experiment due to what they called, quote, low utilization. But in the reality was that these candidates were not passing even a watered down version of what most physicians will tell you is our easiest step exam. And here's a study that they just asked nurses to evaluate their own competency. So you have these objective tests that show that nurse practitioners, at least in these studies, were not able to pass the same exams as physicians. Well, when you ask nurses to rate themselves in their competencies, they are not rating that they have the adequate competencies to provide evidence-based care for patients. And this graph shows in the red dot are nurses with an RN degree, associate's level or diploma level. The orange one is a bachelor's degree. And you see that they rank themselves as needing improvement in all the competencies. And then for the green little triangle, those are nurse practitioners. And you see that even they rank themselves as needing improvement in all competencies. So clearly they're not getting the education and training that they even themselves think that they need. And we all know that the problem is something that was described by Dunning and Kruger, psychologists, that shows that a lot of times we just don't know what we don't know. We know that when we first learn about a subject or before we even know anything about it, we may rank our confidence of our knowledge as being quite high. And this is sort of like when you very first start medical school or your clinical rotations. And then as you get into it more, you start to feel really out of your depth and you realize how little you know. You start to feel that imposter syndrome. And then as over time, slowly, as you gain more experience, your confidence begins to increase again, although it may never get up to that point where you started, because you just realize how much more there is that you don't know. And it's really dangerous if you're over here on the left side of this curve, because that's when you can really get into trouble. So nurse practitioners have been seeking what they call full practice authority. And the idea of this is that they would be permitted to treat patients. They say here, evaluate patients, diagnose, order, and interpret diagnostic tests, and initiate and manage treatments, including prescribed medications, under the exclusive licensure authority of the State Board of Nursing. And they are make an argument for this full practice authority. They say that if this is permitted, that this will increase access, especially in underserved areas. So I want to go through some of these myths and explain why they're not quite accurate. So, first of all, let's just break down the argument about access. So, we always hear it said we need to allow independent practice because we have a lack of access. Well, the Lancet published a study in 2018 where they analyzed healthcare in low to middle income countries across the world. And what they found out is that more people die worldwide due to poor quality of care than those who die due to lack of access of care. So just because you have access doesn't mean that you're going to have good outcomes. In fact, it may be more dangerous to give patients access to care that is not of good quality. And then the other issue is that the nurse practitioners argue that they will provide more primary care and they will work in underserved areas. But the truth is that we're not seeing that happen as much. The AANP says on their website that 78% of all nurse practitioners practice primary care. But the Health Resources Service Administration found that it's actually closer to 48%. So they may be graduating in primary care, like be a family nurse practitioner, but they're not actually working in that field. And so 48% were practicing primary care in 2012. The rest were practicing in subspecialties, in internal medicine, in surgery, in pediatrics, in psychiatry and mental health. And then 20% is other, which I don't know what that means. But we do know that we're seeing a 40% decline in nurse practitioners choosing primary care since 2004. I mean, probably for the same reason that doctors are not as interested in primary care. It's a tough field, even as important as it is. It's not easy to practice good quality primary care. The other issue regarding rural care, we hear the argument that if we allow independent practice, that we'll see more access in rural areas, and that hasn't turned out to be the case. In fact, 77% of nurse practitioners practice in cities and suburbs, and only a quarter practice in rural areas. This is a map from the AMA. They have practice mappers across the country, and they show where physicians practice and where nurse practitioners practice, and you see there's always a significant overlap. There's very rarely more nurse practitioners in rural areas. In fact, family physicians are the most common clinician to work in a rural and underserved area. We also know that independent practice states have not seen the promised increase of nurse practitioners into those areas. And, efforts to get more nurse practitioners to enter into primary care have not been very successful. In 2012, the federal government spent 179 million, sorry, I missed an M on the slide, $179 million to try to encourage nurse practitioners to enter into rural and underserved work. And after 5 years, just 9% of the enrollees in this program went into rural areas. A quarter went to underserved, and only 12% elected to work in primary care. The other thing that's interesting is, we see this argument that will have them come into rural areas, but there's not a lot of incentive for physicians to enter into rural areas. For example, the federal government has incentivized nurse anesthetists and anesthesia assistants to work in small rural hospitals by something called pass-through legislation, which allows them to be paid at a higher rate. And anesthesiologists would like to go to these rural areas, especially if they will make a little bit more money. That would make it worth their while to work in these areas that are not easy to access. But the government declined that. They said, no, we'll pay extra to nurse anesthetists, but not to anesthesiologists. So some of these policies have not incentivized physicians to work in rural areas to the same extent. The second argument that the AANP makes as far as why nurses should practice independently, they claim that it will streamline care and make care delivery more efficient. So let's talk about not just efficiency, but quality of care. The AANP argues that there are 5 decades of research showing that nurse practitioner practice is safe and effective. So let's look at those studies and really break them down. Probably the most important and influential study or meta-analysis was performed by Cochrane, and it was released in 2018. And the name of the study was called Nurses as Substitutes for Doctors in Primary Care. And if you just read the conclusions, then it certainly sounds like nurse practitioners really can do the same thing as physicians. What they say is that for some ongoing and urgent physical complaints and for chronic conditions, trained nurses probably provide equal or possibly even better quality of care compared to primary care doctors. and they probably achieve higher levels of patient satisfaction. So that sounds pretty good. It sounds like great. Let's just let nurse practitioners practice independently. But what did these studies actually look at? There were only 3 studies of 18. First of all, let's just point out over 50 years, they only found 18 studies of adequate quality to assess. Of these 18 studies, just 3 of them were performed in the United States. The single best scientific United States study was done by Hamani, and it was published in 1999. This was a study at the Veterans Administration in Baltimore, and it included 450 patients. Nurse practitioners were 100% supervised in this study. And the conclusion of the study was that in a primary care setting, nurse practitioners may utilize more healthcare resources than physicians. They ordered more lab tests, they ordered more imaging studies, they utilized more healthcare resources than both medical residents and attending physicians. And they also had a higher hospitalization rate, even though their patients were not as sick as patients of the attending physicians. The second United States study included in the Cochrane database was by Mary Mundinger in 2000. This is a study that is cited all the time in the literature, and it compared 17 physicians with 7 nurse practitioners in community outpatient primary care clinics. There were about 1,300 patients. They were low-income, transient Hispanic women. They were low-risk patients. They were mostly in their 40s, and this measured the patient's health status over a 6-month period, a health status that you really wouldn't expect much, considering that these were low risk patients. At the time, New York required collaborative practice, and these nurse practitioners were assigned a physician mentor. So although you often hear that these nurse practitioners were practicing independently, they always had access to a physician, and they did have collaborative practice. And also, it's important to note that nurse practitioners in this study were actually at a doctoral level. They were all academic professors of nursing, and they had received an additional year of a residency training to prepare for the study. And that wasn't actually disclosed in the original article, but it was found in additional writings about it. So the ultimate result of the study was that there was no difference in health status or health service utilization in the 6-month period, but that nurses did provide more education, ordered more laboratory tests. There was no difference in referrals. Patient satisfaction was slightly higher for physicians. That's really, I mean, we know patient satisfaction is not correlated with outcomes or quality, but just of interest. And what's really interesting is that Cochrane said that this Mundinger study actually had the highest amount of bias of all the studies that they reviewed, because the subjects were not randomized, nobody was blinded, the assessments were not blinded, and the authors only reported favorable data. So there's a lot of problems with this study. And then the third United States study was by Lewis. It was performed in 1967. It was only 66 patients. And really, it wasn't even designed to evaluate the care provided. It was just designed to see if patients would accept seeing a nurse practitioner, and they would. Now, the rest of the studies were performed outside of the United States. There were several in the United Kingdom. 2 of them had to do with telephone triage, found that nurses could safely provide telephone triage. Great. Then there was a study by Schum in 2000. There were about 800 low-risk patients that were having minor medical complaints. Now, this study excluded any patients that were high risk, and they had a list of criteria. If they had chest pain, shortness of breath, if they were elderly, there were all sorts of reasons. So these were low-risk patients, and they always had access to a physician. And what they found was that of the nearly 800 patients, low risk, about a quarter required physician intervention. And ultimately, the researchers could not draw any conclusions about the safety of the care because the group studied was not large enough. In Venning 2000, this was a study designed to simply evaluate the cost effectiveness of nurse practitioners. It was only a 2-week follow-up of 1,300 patients. There were always physicians available to work with the nurse practitioners, and nurse practitioners required assistance about 17% of the time. And ultimately, the study found that nurse practitioners spent more time with patients, performed more tests, had more follow-up visits, but the study could not answer the question that it was designed to ask, which was whether or not they were cost effective. Mower in 2001, a supervised study following protocols, just evaluating whether or not we could prevent heart attacks and strokes by following certain risk factors. They found that nurses could do a good job. They followed a protocol very well, but unfortunately, those interventions did not actually have any impact on outcomes. And then in the United Kingdom, a few specialty studies. There was a rheumatology study that was 100% supervised. Nurses were following protocols for chronic diseases, and they were found to be cost effective and did a good job. And then a GI clinic, which had nurse practitioners evaluate patients after an endoscopy. They removed any high risk patients from the group, and they found that following an endoscopy, nurse practitioners could do a good job of following up with patients. Now, those were the UK studies. In the Netherlands, there were several studies. One included first contact primary care, but it was inadequately powered, so they could not determine the safety. The second also was evaluating diabetic patients, and they found that there was not enough patient sample to assess the quality of care. And then finally, in 2010, an evaluation of patients at risk for coronary artery disease, a supervised practice, no high risk patients, and the nurse practitioner patients did very well with risk reduction when the nurse practitioners followed physician created protocols. There were a couple important Canadian studies, a study in 1974, which is very famous, called the Burlington Trial. This was one of the first studies to evaluate nurse practitioner use, and these were nurse practitioners that worked side by side with their physicians, two nurse practitioners. They found that nurse practitioners were as safe and effective as a physician 55 to 67% of the time. And so this is where we often hear that, they're as good, but what you don't hear is that they may not be as good up to 45% of the time, but instead rather you hear the positive side. And then the second was a study in 1978, which was a supervised study and found that patients got good outcomes when they were being cared for by a physician supervised nurse practitioner. And then just a smattering of other studies that were included in Cochrane, a South Africa study where nurse practitioners monitored HIV therapy following a protocol, a study in Sweden following stable chronic inflammatory arthritis patients, an interesting study in Spain that involved supervised nurse practitioners evaluating low-risk patients with minor issues like burns, diarrhea, back pain, cold symptoms. And what they found was that the nurse practitioners could manage about 72% of burns, injuries, and diarrhea, but they could only independently manage a minority of the patients of low back pain, colds, and urinary symptoms. So go back to the summary, which was nurse practitioners can do as good a job or better than physicians. And I just showed you all of the studies that Cochrane analyzed. And you see the limitations. First of all, every single study involved physician supervision or physician created protocols. Every single study pretty much excluded high risk or complex patients. These were not undifferentiated problems. These are patients that had known medical conditions. They already had diagnoses for the most part. Generally, the studies had very small sample size, short follow-up, non-diverse patient populations. So really a lot of limitations and a lot of questions. And basically, to me, it just means that we need a lot more study before we can say, oh, this is fine. Well, the VA has explored that, of course, because they did permit independent practice. They came out and said that there's really no difference in quality of care. You see that here in the evidence summary results. No difference, no difference, no difference. But then take a look at the strength of the evidence. And what you see here is insufficient, low, insufficient, low, insufficient. So based on basically very poor, insufficient data, they've decided to allow independent practice. The truth is that we also, while we don't know if it's safe or effective, we do know that compared with physicians, nurse practitioners, and physician assistants do order more laboratory and radiology tests. They perform more unnecessary skin biopsies. They prescribe more medications, including unnecessary antibiotics, psychotropic medications, and opioids. And they've been found to have poorer quality of referrals to specialists. And it's especially concerning now that we have a growth of what we call diploma mills, which are these programs that will basically accept anyone that applies. And here's a list of 9 nurse practitioner programs that have 100% acceptance rate. So anyone that applies will get in. And we also have a new type of program, which is called the direct entry, which means that a non-nurse, anyone with a bachelor's degree in any subject, art, economics, it doesn't matter. They can become a nurse practitioner without ever having worked a day as a nurse. And this is a common and new phenomenon that's rapidly growing. And of course, we know that a lot of nurse practitioner training programs are online, often 100%. And I just like to show this picture because this is a nurse practitioner who he talks about attending the direct entry program. He was a psychology major, and then he went to a direct entry program and he became a nurse practitioner. And it says here, first day of work as an NP, orientation training for the next 2 weeks, and then I'm all on my own in my primary clinic. So this is this adequate to be able to treat patients? That's the question. And of course, physician assistant programs, they're not quite as egregious in the online world, but they're getting there. I mean, there are several online PA programs now. And so again, I think they're probably following because of some of these economic pressures and the pressure to compete. And, so what we're seeing are bad programs, but we're also seeing students that are interested in these bad programs. And here's a couple of screenshots. Someone that said that they want to go back and get their psychiatric nurse practitioner degree, which unfortunately, this is the hot thing right now, is everybody wants to become a psychiatric nurse practitioner because apparently it's more lucrative. And they're asking, is there a school out there without proctored exams? I'd prefer open book, open notes exams. Another person over here saying, quote, I'm looking for the absolutely easiest online master's to doctorate program, and saying, that they were happy that they went to a really good program for their master's, but they said, quote, I am too old and have too many responsibilities to do a program like that again. And they really want, they put at the end, just down and dirty and to the point. So this is the type of education that some people are seeking. And the schools are ready to answer that. Here you see discussions, we see them all the time on social media about what programs are offering, and people complaining, some students complaining about it, saying, why are we getting all this research and theory instead of actual real world medicine and practice? And a student writing and saying that they had, during their nurse practitioner training, only one 2-hour class on how to read an EKG and one 2-hour class on how to read a chest x-ray. So this is the type of education that some of these diploma mills are pumping out students with, only having spent 2 hours studying an EKG and 2 hours on a chest x-ray. And then, of course, we see all these posts, people graduating and not having the acumen to know what to do, or even probably what resources to go to. They're asking, where do I find a book on how to interpret labs? And hey, I'm going to be seeing pediatric patients, but I really never did this before. And what should I do? And another person saying that they've never gotten any experience doing PAPs in their training. And what should they do to try to learn how to find the cervix? And another person saying, how do I treat blood pressure? I mean, just in here saying, I just Googled hypertension algorithms. And this is really not, these are not made up. This is what is happening across the country. And to the point where the AANP president, Sophia Thomas, actually wrote an article asking and begging these nurse practitioners and students to stop going on social media to ask these questions because, of course, it's not the best place to get information, but also because it's not really making them look very good. It's showing some possible deficiencies in the educational process. And, the truth is that patients don't know. It's very confusing. There are 183 different nursing certifications. You see a string of letters behind someone's name, and it's really hard to even make out who they are. I always tell patients sometimes the least letters behind the name means the most credentials. We have a huge increase in this doctorate degree, so everybody can be a doctor. We have a doctor nurse. We have a doctor PA, which is the doctorate of medical science. And the other thing is that some of these non-physician practitioners have appropriated terms that we use as physicians, like board certified or residency or fellowship. They don't mean the same thing, but yet people hear those terms and they assume that they mean the same thing. And we know that these groups are really doing a good job with their public relations to reach out to patients to tell them, hey, we can take great care of you. Nurse practitioners have a slogan called "We Choose NPs," and that reaches directly to patients to say, you should get your care from us. We're just as good. We're better, in fact, sometimes. PAs have a slogan called "Your PA can" or "Your PA can handle it." Again, trying to encourage patients that they can do the same thing as physicians. One thing that is concerning is seeing these non-physician practitioners just hanging a shingle, especially in independent practice states, and calling themselves specialists. I mean, I see some of these screenshots, just accepted a job with nephrology and oncology. Does anyone have any books to start learning and treating? Like that, it seems like that can't even be possible. Here's a nurse practitioner who is calling herself a rheumatologist based on the fact that she's taken some courses from the American College of Rheumatology. As a family physician, I couldn't take a course and call myself a rheumatologist. I'd be sanctioned by the Board of Medicine. But yet there's nothing stopping nurse practitioners from doing this. And here we often see this psychiatric nurse practitioners calling themselves psychiatrists. And patients don't know. They just see doctor and they don't know to ask. As I mentioned, a lot of psych and nurse practitioners are a big thing right now, but also all sorts of different cash-based practices. And it's really worrisome. Even in my area, which is supposed to be a supervised state, we're seeing nurse practitioners opening up ketamine clinics. And there's something called the elite nurse practitioner, which is a guy that encourages nurse practitioners to hang a shingle and encourages them to do these cash-based practices to, as he says here, they're very lucrative. And and he has all sorts of peptides and infusions and medical marijuana and hormones. And just, it's really, when you look at the website, it's really shocking. And I mean, yes, you can say let the buyer beware, but a lot of times I think these patients are desperate for help or they don't know any better, and it's really dangerous. And of course, as a physicians, we may be the ones that have to clean up after these messes. And you're going to hear a story from Dr. Townsend after I'm done sharing her experience with one of these nurse practitioner hormone clinics and why they're so dangerous. The other thing about the public is that they don't realize that nurse practitioners are not held to the same standard of care in a malpractice case. Maybe this is something that is going to change, but up until now, case law has repeatedly demonstrated that a jury should be instructed that nurse practitioners are not held to the same standard of care. In some cases, physicians have not been permitted to testify because they're not in the same field. They say they only can have another nurse practitioner testify against the nurse practitioner. So this is what we've seen in case law, and this may make it harder for patients to receive justice. And then we know that boards of nursing are really struggling to sanction nurse practitioners that are not practicing adequately. First of all, they're stretched very thin. And I actually feel for them, because when I looked at Florida, you look at the Board of Medicine in Florida, and there's like 13 people on the board, and they have to be in charge of like something like 40,000 doctors. And for the Board of Nursing, there was maybe 10 or 12 people on the board, and they were in charge of like 100,000. I mean, it was way different. It's way more responsibility because they are in charge of all nurses, LPNs, RNs, and nurse practitioners. So it's a lot for them to do, and they can't keep up. In fact, California Nursing Board got in trouble because they faked some documents to show that they were investigating when they weren't. I wrote about what you're going to hear from Dr. Townsend in Texas, where the Board of Nursing did not do a good job of protecting patients. And we're seeing this in states across the country. I mean, we really need our nurses. Bedside nurses are really one of the core bedrocks of our healthcare system. And there's a nursing shortage already. And we know that nurse practitioner training has reduced the number of registered nurses by about 80,000 nationwide. And that's because many are leaving the bedside to pursue provider status, or they're not going into teaching as much. So like I said, usually if a nurse wanted to go further in their education, they would become a PhD and they would become a nursing instructor. Instead, nurses can make a lot more as a nurse practitioner than to teach. And one of the problems is the Future of Nursing report never addressed the shortage of bedside nurses. They focused on increasing bachelor's degrees, but not diploma degrees, which are easier to attain. And in some studies show it can provide just as good, and some studies say even better quality of nurses with more bedside experience. And what I really feel badly about is that so many nurses are afraid to speak out. And I've heard from many of them. They reach out to me privately. Sometimes they can speak out publicly. It's very rare, though. Most of the time, they have to stay silent. And here's why. They're told not to speak out. And if they do, they're punished. This is a slide from the conference, the American Association of Nurse Practitioners conference in 2019, the final talk was given by Margaret Fitzgerald. She's a nurse practitioner educator that has some review courses, and she told nurse practitioners, if you're opposed to full practice authority, you need to keep that to yourself. And here you see a smiley face with a zipper saying the strongest NP voice is silent. So they're told, don't speak out, don't oppose this, even if you're worried about safety. And we need nurses, but we also need physicians. And as you see here, the number of graduates from medical schools and residencies is really relatively flat. And that has a lot to do with the cap on residency funding. Although we've seen an increase in medical schools, we have not seen a proportionate increase in residency slots. And really, the United States ranks 24th out of 28 similar nations when it comes to physician per capita. So we're not seeing as many physicians trained as other countries, and that may have something to do with some of our problems that we're seeing in healthcare access. And doctors are afraid to speak out too. My friend, Dr. Steve Maron, was actually fired. He's the middle thing here, Green Valley doctor. I was fired over op-ed about nurse practitioners. He's a pediatrician with 30 years of experience working in an underserved clinic in a federally qualified health center. He wrote an op-ed responding to an article just saying nurse practitioners are wonderful, but they're not the same as physicians. It was a very gentle and kind op-ed, and he was immediately fired from his job. And then, of course, physicians are losing their jobs, though, even when they don't speak out and they're being replaced. We've seen this happening across the country. And I think, unfortunately, we're going to see it more and more, especially if nurse practitioners continue to have independent practice, because they're selling a bill of goods, which is that they can do the same thing and at less money. And corporations are eager to believe this because, of course, profit, unfortunately, is something that's considered very important nowadays, less so than sometimes quality. So I really want to thank you all for listening. And if you'd like to learn more about this topic, of course, I would encourage you to get my book. And you're always welcome. We encourage you to join us at Physicians for Patient Protection. So I'm going to turn it over to Dr. Amy Townsend so she can share her really inspiring story. And I look forward to talking with all of you more. Thank you so much.